Bismillahirrahmanirrahim. So let's start the fourth session of our CVS unit. So over here, we are going to talk about the preload. The preload. Before that, we were discussing the difference between the preload and afterload, and we had a very broad discussion about cardiac output and stuff like that. So let's move forward to the preload. So the preload is the amount of blood loaded into the left ventricle. That is a preload. Also, how much stretch is on the fiber to contraction. How much stretch is on the fibers prior to contraction. That is also preload. Some books say lengthy instead of stretch. Some books will say length instead of stretch. More preload, more cardiac output. More preload, more work the heart must do, and more oxygen is required. Okay, that makes sense. That the more venous return, or the more preload is entering the heart, the more work the heart must do, and resultantly more oxygen is required. To increase the preload, we have to add volume. The blood in the IVF, what's that? The blood IVF. Give me a second. Add volume. Blood is IVF. What's IVF? IVF preload. Okay. IVF. IVF preload. IVF is embryo. There is in vitro fertilization. You know what does that mean? IVF. Add volume, blood or intravenous fluid. I'm sorry. That is intravenous fluid, IV fluids. Okay, that is IVF. So we are giving the blood to some person, or we are giving the plasma to some person, maybe. That is intravenous fluid. Slow heart rate, more refilling, and more volume. Constricts the veins. Veins force blood into the heart. Veins hold the large blood volume. Response to blood volume. Response to blood loss. Venous constriction. So whenever there is blood loss, there will be venous constriction. Sympathetic stimulation will result in alpha-1 receptors in the veins. So sympathetic stimulation will cause the alpha-1 receptors in the vein to be activated, and that results in the constriction. Okay. To decrease the preload, remove the volume, bleeding, and dehydration. Raise the heart rate, that is opposite mechanism as above, and pool blood in the veins. Mechanism of action, nitrates. Mechanism of action of nitrates, leave the angina and lower the preload, less work for the heart. Okay. To decrease the preload, we have to remove the volume, that is bleeding and dehydration. Raise the heart rate, that is opposite mechanism as above, and pool the blood in the veins. Mechanism of action of nitrates, and that relieves the angina as well, and that lowers the preload, that is less work of heart. Important terms: left ventricular and diastolic volume. Volume in the blood in the left ventricle, the volume of blood in the left ventricle when filled, and filled completely. And left ventricular and diastolic pressure is the pressure in the left ventricle when it is filled. So end diastolic volume is the volume when it is filled, and the pressure is the pressure exerted by that volume when the left ventricle is filled completely. Load forces resisting the flow out of the left ventricle. Okay, heart must squeeze to increase the pressure, needs to open the aortic valve, push the blood into aorta. This is harder to do if the blood pressure is high, aortic valve is stiff, and something in the way, for example hypertrophic cardiomyopathy and aortic subaortic stenosis, subaortic membrane. So in these conditions it is harder to push, because in the case of hypertrophic cardiomyopathy, let's discuss them one by one. So forces resisting the flow out of the left ventricle, heart must squeeze to increase the pressure, and needs to open the aortic valve, push the blood into aorta. It is harder to push when the blood pressure is high. Suppose that this is the left ventricle and it is aorta which is coming out of that. So if the blood pressure is already very high, like suppose the blood pressure is like 140, so the normal systolic blood pressure of the left ventricle is 120. If the blood pressure is already 140, so it must create a pressure of 140 to cause the ejection of blood, right? Or if the blood pressure is even higher, so the right ventricular pressure and volume, the pressure must increase accordingly. If the aortic valve is stiff, so the 120, if the aortic valve is stiff, so the pressure of 120 millimeters of mercury is not enough to open the aortic valve. So more pressure is needed to be applied. In the case of hypertrophic cardiomyopathy, this is the interventricular septum, then it is the right ventricle on the other side. The interventricular septum, that is hypertrophied so much over here that it comes in the way of the aorta. So when the ventricle is contracting, the interventricular septum will be blocking the outflow of the left ventricle. So that is also one of the reasons that the left ventricle left ventricular outflow is increasing. To increase the afterload, raise the mean blood pressure, obstruct the outflow of the left ventricle. Okay, so to increase the afterload, either raise the mean blood pressure or obstruct the outflow of the left ventricle, that is aortic stenosis or hypertrophic cardiomyopathy. To decrease the afterload, lower the mean blood pressure, treat the aortic valve disease, hypertrophic cardiomyopathy, More afterload, more work, and more oxygen is required. Okay, so left ventricle compensates for the increased afterload by thickening hypertrophy in order to decrease the wall tension. Actually, this sound is a little bird is chirping on the top of her throat, so that is disturbing me. I hope it is not disturbing you. Okay, let's continue. I will use my finger. Okay, so the venous vasodilators, for example, nitroglycerin, decrease the preload, and arterial vasodilation, for example, hydralazine, also decreases the preload. So venous vasodilators, vasodilators, which cause the dilation of the veins, like these. So these are the venous vasodilators, for example, nitroglycerin, they decrease the preload. That is why if the veins are dilated, the blood will be pooled inside the veins and that will not be allowed to enter the heart. Then the arterial vasodilators, for example, the hydralazine, that will decrease the afterload. So afterload means the total peripheral resistance is decreased and it is easy to pump the blood into the into the peripheral circulation. So remember that. Now ACE inhibitors and angiotensin receptor blockers decrease both the preload and afterload. Heart rate increases the cardiac output under the physiologic conditions. Heart rate increases the cardiac output. Increases cardiac output. Heart rate increases no. Under physiologic conditions. Okay. So if there is an increase in the heart rate, so that will increase the cardiac output under physiologic conditions, mainly regulated by the sympathetic nervous system, also increased by the sympathomimetic drugs. For example, if we are giving somebody some drug like, for example, dobutamine or stuff like that, so that will also cause an increase in the heart rate. Decreased by the beta blockers and calcium blockers at pathologic heart rates. At the pathologic heart rate, increase in heart rate is equal to decrease in cardiac output. If we have a pathological increase in the heart rate, so the cardiac output will decrease. Cardiac output will decrease if you have pathological increase in the heart rate. Cardiac output is decreasing in that. I can't understand that. At pathologic heart rates, if you have a pathological amount of heart rate, if the heart is beating at some 100 beats per minute, so the cardiac output is decreasing. Okay, I just could not decipher this one. Kindly explain this in the comment section because I could not understand anything of this line. Okay, so this is cardiac output and heart rate. So initially, as we can see, if the heart rate is increasing, the cardiac output is also increasing. But as we move forward, by decreasing the heart rate, the cardiac output also starts decreasing. So it is evident on the graph, and this graph is from the BNB, so it must be right. But I could not understand that. How is it possible even? Like, okay, if the heart is beating so fast that the systolic time is decreased, so if the systolic time is decreased, the heart is not getting okay, got it. So because when the heart rate is increased, this is systolic time. Suppose this is S1, then S2, then again after the diastole we have S1 and S2. So that this is S1 again. So if the S1, the diastolic time is decreased so much, if the diastolic time is decreased to a pathologic level, then the heart has no time to relax. The heart can't relax at all. So because the heart is not getting time to relax or fill itself, resultantly there is very small end diastolic volume. So if the end diastolic volume, left ventricular end diastolic volume is very small, so definitely nothing is there to pump out. So that is how the cardiac output is going to decrease, because cardiac output is the multiplicand or the result of the product. I'm sorry, it is the product of stroke volume multiplied by the heart rate. If the stroke volume is decreasing to a pathologically low level, increasing the heart rate will do no good and the cardiac output will be decreasing. Okay, I guess this is the explanation. If anyone has a better explanation, so kindly let me know. Then we have cardiac output equations. So first we will talk about stroke volume. Stroke volume is equal to end diastolic volume minus end systolic volume. We have discussed that. Stroke volume is basically the end diastolic volume, what the amount of blood that had the potential to be pumped out, and the end systolic volume, the amount of the blood that is now remaining inside the left ventricular cavity. So the sum of these two things, it's not sum, it is something else. So whatever it is, the negative sum of these things, the solution of this question is going to give us the stroke volume. What is the ejection fraction? Ejection fraction is equal to the ratio between the stroke volume and the end diastolic volume. It is the amount of the blood. Stroke volume is the amount of the blood that is being pumped, this one, and the total amount of the potential, the total amount of the blood that has the potential to be pumped out. That is stroke volume divided by the end diastolic volume. So it is end diastolic volume minus end systolic volume over end diastolic volume. We have combined these two equations. Ejection fraction is the index of ventricular contractility, decrease in systolic heart failure. Okay, so whenever there is systolic heart failure, the ejection fraction will decrease, usually normal in the diastolic heart failure. What is cardiac output? Cardiac output is equal to stroke volume multiplied by heart rate. There is a Fick principle. They ask you about this one. So cardiac output is equal to rate of oxygen consumption divided by the arterial oxygen content minus the venous oxygen content. So it is basically the rate of oxygen consumption divided by the difference between the arterial and venous oxygen contents. So this gives us the cardiac output. In early stages of exercise, cardiac output is maintained by increasing heart rate and increasing the stroke volume. In later stages, cardiac output is maintained by increasing heart rate only because stroke volume plateaus after a specific amount of increase. Okay, diastole is shortened with increased heart rate. For example, the ventricular tachycardia, decreased diastolic filling time, decreased stroke volume, and ultimately decreased cardiac output. So this is the explanation of that line. This line over here. That at pathological heart rate, the increased heart rate will decrease the cardiac output. Okay, then let's talk about pulse pressure. Pulse pressure is equal to systolic blood pressure minus diastolic blood pressure. So pulse pressure is directly proportional to the stroke volume and inversely proportional to the arterial compliance. Increase in pulse pressure in hyperthyroidism, aortic regurgitation, aortic stiffening, for example, isolated systolic hypertension in elderly people, obstructive sleep apnea, increased sympathetic tone, anemia, exercise, and so anemia and in exercise. In exercise, we have a transient increase in the pulse pressure because when we are doing the exercise, the body is becoming hyperthermic, and due to the hyperthermia there is vasodilation, so the diastolic pressure will decrease and systolic pressure will increase. Now there is another point which you must remember, that the total peripheral resistance is going to dictate the diastolic blood pressure and the heart rate or maybe cardiac output. So the cardiac output is going to dictate the systolic blood pressure, right? So the total peripheral resistance is going to determine the diastolic blood pressure. Like if we are going to write it like 120 by 80, so this 80 is dictated by the total peripheral resistance, while the 120 or the systolic blood pressure is maintained by the cardiac output. Mean arterial pressure is equal to cardiac output multiplied by the total peripheral resistance. Got it? So mean arterial pressure is equal to cardiac output multiplied by the total peripheral resistance. Mean arterial pressure at resting heart rate is equal to 2/3 of the diastolic blood pressure. Let me revise this. Mean arterial pressure is equal to cardiac output multiplied by the total peripheral resistance. Mean arterial pressure at resting heart rate is equal to 2/3 of diastolic blood pressure plus 1/3 of systolic blood pressure. That is equal to what? That is equal to 2 into diastolic blood pressure plus 1/3 of the pulse pressure. So somehow these two equations are equal to each other. So keep that in mind. You may also write it like 2 diastolic blood pressure plus systolic blood pressure divided by 3 will give us the pulse pressure, and that is also equivalent to the diastolic blood pressure plus 1/3 of the pulse pressure. Now we'll talk about the work of the heart. The myocardial oxygen demand is increased by increased contractility, increased afterload proportional to the arterial pressure, and increase in the heart rate. The diameter of the ventricle that will increase the wall tension. There is some formula. Okay, we'll see that formula. That formula is called as the Laplace law, and Laplace law is, there are different versions of Laplace law. I could not never understand that why there are so many versions of that. So but the diameter increases the wall tension. Okay, so all of these things are increasing the myocardial oxygen demand, and resultantly they are increasing the work of the heart. Uworld point is perfusion of the heart is initially during diastole. The systolic reduction of the coronary flow is greatest in the subendocardial myocardium or the left ventricle. Cardiovascular response to exercise. It is a very highly tested upon concept. The process begins with the muscle contraction, ATP consumption. So whenever there is muscle contraction, it will cause the consumption of the ATP. There are a lot of areas during the muscle contraction where the ATP can be consumed. For example, during the activation of the myosin heads, right? The ATP is consumed over there, and then for the detachment of the it is used once over there. For the detachment of the myosin head and converting them into their active position, this is the myosin head. This is attached myosin to the actin. We need ATP to displace it from the attached position and then take it back to the coax position so that it can bind to further actin molecules. So ATP is consumed over there. Then ATP is consumed when we are bringing the calcium back to the sarcoplasmic reticulum after the contraction has taken place, and a lot of other areas are requiring the ATP during the muscle contraction. So the process begins with the muscle contraction. ATP is consumed in the muscle contraction. I was trying to make a connection between the CVS and the MSK. Okay, so ATP is consumed, then oxygen consumed, need more ATP. The result in local hypoxia in the muscle tissue and vasodilation occurs. Multiple VD mediators released in plasma. Multiple vasodilation mediators are released into the plasma. For example, adenosine generated by the ATP consumption. ATP was consumed over here. Resultantly, adenosine is secreted into circulation, and that is a vasodilator. Then lactate, then carbon dioxide and potassium. All of these agents are vasodilators. Remember this thing, that adenosine, lactate, carbon dioxide and potassium are vasodilators. Now vasodilation will decrease the total peripheral resistance and the diastolic blood pressure will decrease, because as we saw over here that the diastolic blood pressure is dependent on the total peripheral resistance. So sympathetic nervous system activated. So very first thing was the vasodilation. Why was vasodilation over there? Because ATP is consumed, oxygen consumed, need more ATP, local hypoxia will be there, and hypoxia is a potent vasodilator. On top of that, there are mediators of vasodilation that are being released, which include the adenosine, lactate, carbon dioxide and potassium. Sympathetic nervous system activated, there will be increased heart rate, that will lead to increase in cardiac output to meet the metabolic needs of the body. That results in increased systolic blood pressure, venous constriction, increased preload and more increase in the cardiac output. Vasoconstriction in some areas, gut and skin, redistributes the blood to important areas, for example the heart and the muscle. Net result is increased systolic blood pressure and decreased diastolic blood pressure. Okay, so the pulse pressure will increase, like suppose we have blood pressure 140 divided by 60, the total pulse pressure is 80 in contrast to the normal one, that is 40. So the net result is increase in the systolic blood pressure and a decrease in the diastolic blood pressure. The pulse pressure increases, mean arterial pressure remains slightly constant, only increases 20 to 40. So mean arterial pressure is slightly constant. Okay, fast heart rate shortens. Okay, so if there is fast heart rate, now that is very important concept, that when the heart rate is increased, this shortens the diastole, less coronary filling time, only way to get more oxygen in the coronary vasodilation. Okay, so we need to do the coronary vasodilation to get more oxygen, because if the diastole is shortened, the coronary filling time is less. The coronary filling time is less. Okay, yeah, so the coronary filling time is less, only way to get more oxygen is coronary vasodilation, that increases the blood flow. The heart cannot extract more oxygen unlike other tissues. Cardiac tissue extracts maximum oxygen from the RBCs, cannot extract more to meet the increased demand. So there are some tissue like the muscles or other muscles have myosin, not myosin, myoglobin. Yeah, because of the presence of myoglobin, the muscles can extract increased amount of oxygen, but the heart can't do that. Now there is Kaplan question bank. Exercise has two types: dynamic, increased blood flow due to the metabolic vasodilation of arterioles, and static, that is weightlifting. So exercise has two types, like the dynamic exercise, the running and the sprinting, that increases the blood flow due to the metabolic vasodilation of the arterioles. And then we have static one, that is including the weightlifting. In the skeletal muscles, they contract. The skeletal muscle undergo contraction that compresses the blood vessel. It increases the vascular resistance and decreases the blood flow. So there are two types of exercises. When you're talking about exercise in general, talk about the vasodilation and the sympathetic innervation and net pulse pressure increase and heart rate increase, stuff like that. But when you're done with that, now take the differential that either it is dynamic or static exercise. So then you have to differentiate between the two. Moving to the lucitropy. Now it is the third time I'm talking about this one. Now it is no more ignored. Lucitropy is a myocardial relaxation. It is opposite to the contractility. Contributes to the increased preload, that is increased cardiac output. Increases with exercise. Mediated by the SERCA. What is SERCA? SERCA is this channel that is present on the sarcoplasmic reticulum and that brings the calcium back. Okay, so increases, okay, mediated by the SERCA. SERCA takes up the calcium and mediates the relaxation. SERCA is regulated by the protein called as phospholamban or PLB. Phospholamban is an inhibitor to SERCA. Sympathetic stimulation beta receptors lead to so beta receptors that phosphorylate the PLB. Okay, that is going to phosphorylate the phospholamban. Decreased PLB increases the SERCA. That will lead to a faster relaxation and faster contraction. So here we can see the phospholamban. If it is phosphorylated, it can no more inhibit the SERCA. Normally it does, but if it is phosphorylated by beta-adrenergic stimulation, for example, it cannot inhibit the SERCA anymore, and the calcium uptake by the sarcoplasmic reticulum is enhanced. And if the calcium is leaving the cytoplasm, it is no more available to the contractile apparatus, and resultantly will have this decrease in the sarcoplasmic reticulum, blah, blah, blah. If there is decreased calcium availability to the contractile apparatus, the contraction will be inhibited and there will be relaxation or lucitropy. So here you can see the exercise physiology. Exercise begins. There will be muscle hypoxia. Muscle hypoxia result in vasodilation. If there is vasodilation, there will be decreased total peripheral resistance, given that the exercise which you are doing is not static. For example, it is not the case in the weightlifting. We are talking about running or some dynamic exercise. So when there is decreased total peripheral resistance, there will be either decrease or maybe decrease in diastolic blood pressure, or maybe it remains unchanged, but you may say a decrease for the conceptual purposes. Decrease in total peripheral resistance will cause an activation of sympathetic nervous system. Now sympathetic nervous system will act on the peripheral vessels, causing the venous constriction, that cause an increase in the preload and end-diastolic volume, and the arteriole constriction that will cause an increase in the total peripheral resistance and increase in the afterload. And if the afterload is increasing, the diastolic blood pressure will either no, that is a minor thing, so it does not affect the diastolic blood pressure. Just forget about this thing. Okay, total peripheral resistance decreased, diastolic blood pressure decreased, that's it. Now we are talking the compensatory response for that. Sympathetic nervous system will be activated and preload will be increased. On top of that, arterial constriction will maintain the blood pressure or even increase that. Then we have sympathetic activation on the heart. Heart will increase the contractility. Increasing the contractility will increase the end systolic volume, and that will lead to increase in ejection fraction. Also, increased contractility will cause an increase in the cardiac output. Sympathetic activation of the heart will cause an increase in the heart rate, and heart rate increase can cause increase in the cardiac output. Why so? Because cardiac output is the product of stroke volume and heart rate. So if the heart rate is increasing directly by the sympathetic activation, that can increase the cardiac output and ultimately increase in the systolic blood pressure. Then heart rate, the sympathetic activity also increases the lucitropy. So here we have seen lucitropy. Over here, this is lucitropy. Increased relaxation or faster relaxation leads to faster contraction. So there will be lucitropy. Lucitropy will increase the preload or end-diastolic volume, that will ultimately lead to increase in the cardiac output. Good. Now let's talk about flow equations. So flow, cardiac output is equal to delta P over total peripheral resistance, change in the pressure divided by the total peripheral resistance in the cardiac output. Flow is equal to velocity multiplied by area. So let's talk about flow equations. The flow for the cardiac output is equal to delta P, the change in the pressure divided by the total peripheral resistance. The flow Q is equal to velocity multiplied by area. Resistance and compliance. Resistance is equal to resistance to the flow, and compliance is the distensibility of the vessel. So compliance is basically how much a vessel can distend, and the resistance is the resistance to the flow of blood across the blood vessel. In the stiff vessel, increased resistance and decreased compliance. For the stretchy vessel, we have decreased resistance and increased compliance. High resistance, low compliance, and vice versa. Blah blah blah. So total peripheral resistance, resistance to the flow, more work for the heart. What resists the forward flow of the heart? Type of vessel, for example, pipes and tubes, and thickness of the blood, that is viscosity. So the peripheral resistance is basically affected by these things. Resistance to the flow, more work for the heart. What resists the forward flow of the heart? Firstly, type of vessel. Okay, the pipes or the tubes through which the blood has to move. And then thickness of the blood, that is viscosity. Types of vessel. It can either be arterioles or veins. Arterioles are the resistant vessel or the resistance vessels. Major determinant of the total peripheral resistance. Vasoconstriction is equal to increase in the total peripheral resistance, and vasodilation will result in a decrease in the total peripheral resistance. Veins provide most of the blood storage capacity. Then viscosity depends mostly on the hematocrit. Low viscosity is seen in the cases of anemia, and high viscosity is present in polycythemia, multiple myeloma, hyperproteinemia, and spherocytosis. What is the effect of radius on the resistance? Changes in the radius, large changes in the resistance. Okay, whenever there is a change, a minute change in the radius will result in a dramatic change in the resistance. So here you can see the driving pressure delta P over flow is equal to forget about this thing. It is viscosity basically. Okay, so viscosity multiplied by length divided by radius raised to power 4. So here is the resistance. Resistance is equal to, or you may say that resistance is equal to 1 over radius raised to power 4, because this is the highly tested upon concept. They ask you that if they cut short the radius by half, or they increase the radius, if they double the radius, so what will be the effect on the resistance and vice versa. Okay, so let's see this over here. Series and parallel circuits. Okay, you may have discussed this, or you may have studied this in your high school physics. Human organs arranged in human organs, all of them, they are arranged in a parallel configuration. Suppose that this is I'm talking about the parallel configuration, but before that we need to differentiate it from the series. It would be series if we had a attachment like this is the heart, it is attached to the kidney, and the same connection is going to the brain, and same connection is going to the heart, lungs, and same connection is coming to the gonads and stuff like that. So this would be our series connection, but our connection is not in series. We have like the heart is over here, and this is the blood supply, the aorta coming from the heart. It is supplying to the brains, to the lungs, to the kidneys, to the gonads, to the other organs. So all of these organs are in a parallel connection with each other, and if they are in parallel connection, the resistance formula looks something like that. So resistance adds up differently in series and in parallel. So if it was like this, so in that case the total resistance of the vessel in series would be total resistance equal to resistance in 1, 2, 3, 4. So in that particular situation, if it would be in series, so maybe that last organ, that would be, suppose that gonads or maybe the brain, it would not have enough amount of the blood supply, because the cumulative resistance till this point is so much that the heart cannot push the blood any further. We're just talking about hypothetical condition because it is not present in the human body. Human body has this type of circulation. Total resistance of the vessel in parallel. The total resistance is equal to 1 over R1, 1 over R2, 1 over R3. So according to this one, more organs you add to something, there will be decrease in the resistance. The total resistance is decreased and the afterload is decreased. This particular situation is seen in two situations. For example, when the woman becomes pregnant, there is an addition of an organ that is called as placenta, right? And if the placenta is added, the total afterload is decreased because there is now additional pathways through which the blood can flow. So the afterload is decreasing due to this physical law that when you add anything in parallel to something, so the total resistance decreases. Secondly, if we have any arteriovenous fistula formation, like this is the artery and the vein is connecting directly to that. For example, we make an arteriovenous fistula for the case of hemodialysis or stuff like that, or maybe in some pathology if the arteriovenous fistula is decreased. Now this is a shunt pathway that is being created, and when there is shunt creation, so the total resistance is decreased further because this is an addition to the total resistance that was conferred by the circulatory system, and resultantly there is a decrease. Maybe this is not a best example for this one, but placenta is a better example. So remember the placental example. Organ removal, for example, the nephrectomy, increases the total peripheral resistance and decreases the cardiac output. That is such a beautiful example. You remove one kidney, you remove this component, and the total resistance increases. The total peripheral resistance is increased, and now there is decreased cardiac output. Uworld point is removal of the kidney or any other organ increases the total peripheral resistance as the organs are arranged in parallel, and decreased cardiac output. Normal arterial blood pressure is equal to mean arterial pressure, cardiac output multiplied by the total peripheral resistance. If the total peripheral resistance is increasing as we have removed one kidney, so resultantly the mean arterial pressure will also increase. No, sorry, I'm really sorry, I just messed it up. If we are removing a kidney and the total peripheral resistance is increasing, the cardiac output is decreasing. So there is a fine balance between these two things and the mean arterial pressure remains constant. Okay. Decreased total renal blood flow. There is only one kidney. So the total renal blood flow was about 20% with each heartbeat. And since we have one kidney left, so that is just 10% because one kidney is being removed. So that is a special scenario with the kidney transplant, but we can use this scenario for any other organ as well. Application of flow equation. Flow is equal to cardiac output is equal to delta P over resistance, which means the change in the pressure divided by the resistance which is offered. Okay. Blood flow to the body is equal to cardiac output. Delta P is equal to arterial pressure minus the right atrial pressure. You may also say that it is the left ventricular end systolic pressure, and the right atrial pressure is the total venous return. Okay, so resistance is equal to total peripheral resistance, that is equal to systemic vascular resistance. Forget about that, what I just said. Delta P is equal to arterial pressure minus the right atrial pressure. Okay. Okay, got it. Because this is the arterial side and this is the venous side which is connected to the right atrium. So this is the difference between the arterial and the venous systems. Then the blood flow to the lungs is equal to cardiac output. Delta P is equal to pulmonary artery pressure minus the left atrial pressure. Now the dynamics are changed. If we are talking about the body, will take the difference of the arterial pressure from the right atrial pressure. But if we are talking about the cardiac output of the lungs, so in that particular case, the pulmonary artery pressure must be the difference between the pulmonary artery pressure and the left atrial pressure must be taken. Okay. Then the pulmonary artery vascular resistance. Okay. You may also take resistance in the pulmonary artery vascular resistance, and then we can apply this to this equation. The blood flow in the systemic circulation is the same in the pulmonary circulation. The blood flow in the systemic circulation is the same as that in the pulmonary circulation. That is very important. The total amount of the blood that is entering the lungs is equal to the total amount of the blood that is entering the body. The pulmonary circulation is low resistance and high capacitance circulation. It is low resistance, which means that resistance which is offered by the pulmonary arteries is lesser in comparison to the aorta or the systemic circulation. And secondly, it is high capacitance, which means that the pulmonary resistance can dilate to a greater extent in comparison to the aorta. And if you are confused in these things, so remember, think it like we are subtracting the sink from the source. Like this is the source of the pressure. This is the starting point. You may say that so we are talking about the pressure changes. So this is the starting point of the pressure, that is when the blood is pumped into the aorta, that is the arterial pressure, and then it circulates all the way through the body and stuff like that, and then it comes back to the right atrium. So this is the end point. So we are subtracting the end point from the start point. Same is in the pulmonary circulation. The pulmonary artery is the start point and the left atrium is the end point. So for the pulmonary circuit, we are subtracting the end point pressure from the start point pressure. You may take it like that as well. Velocity and area. Flow is equal to cardiac output. So flow Q can be taken as cardiac output, that is equal to velocity multiplied by the area. Cardiac output moves through the system. That is same flow. Cardiac output moves through the system. Different vessel, different area and velocity. If the area increases, the velocity will decrease because velocity is inversely proportional to area. Cardiac output is equal to velocity multiplied by area. Multiplied by area, something like that. So we have to find the velocity. Velocity is equal to cardiac output divided by area, and so velocity is inversely related to the area and vice versa. Capillaries have highest total cross-sectional area and the lowest flow velocity. Why is, you can think the capillary is very small, but capillaries are arranged in parallel to each other. This is the capillary, suppose over here there is a capillary. So all the capillaries are arranged in parallel to each other, and the total surface area is so much and so high that the total amount of the resistance that is conferred by the capillaries is the minimum, is decreased, because the total surface area or the cross-sectional area is so less that the resistance is decreasing. Resistance is also inversely proportional to the area. Okay. So there is least amount of resistance in the capillaries. On top of that, there is the lowest flow velocity as well, because velocity is also inversely proportional to the area. Okay, we need the slowest velocity because the capillary is the area of exchange of the material between the organ and the system of the blood and all that. Flow properties of the blood vessel. Property, highest and lowest. Flow, that is, there is no highest and lowest value for the flow. Area is highest for the capillaries and lowest for the large arteries. Velocity is the highest in large arteries and lowest in the capillaries because the velocity is inversely proportional to area. Then we have resistance, that is highest in the arterioles and lowest in the veins. I'm sorry, I take my words back. The resistance is not lowest in the veins. In the capillaries, the resistance is lowest in the veins. And the change in pressure is highest in the arterioles and lowest in the veins. Okay, now let's talk about the Laplace law. Tension is directly proportional to pressure multiplied by resistance over 2 into H. What is H? Okay, we'll discuss that. What is H? Okay, so the wall tension or wall stress is measured by the Laplace law. This is the tension, wall tension or the wall stress applies to vessel and the cardiac chambers. Increase in tension will increase in the oxygen demand, and ischemia and angina can occur if we have increase in the tension. Okay, afterload increases the pressure in the left ventricle. We know that hypertension, aortic stenosis, that will increase the wall tension and there will be pressure overload. So how is the pressure, the wall tension increasing? Suppose that we are saying that if there is hypertension, right? So if there is hypertension and the ventricle has to pump or push harder, so the ventricle has to create a higher pressure. Higher pressure must be created inside the ventricles to create the pressure. Higher pressure must be created inside the ventricles to push the blood out into the aorta. So resultantly, increasing the pressure is increasing the tension. Now, this explanation is valid if we accept that this equation, that is tension is directly proportional to pressure multiplied by resistance over, it is directly proportional to over 2 into H. I guess it is H is, what's H? I don't know. H is maybe height. What's H? Let me see that. So Laplace law states that, yeah, blood vessels. So Laplace law for the blood vessel is the, over here, it is PR over 2. I think H is constant. I have no idea what H is. So tension is equal to PR. Okay. Okay, H is the wall thickness. Okay, got it. Because I don't know, because here they have written U, but transmural pressure multiplied by radius over 2 into wall thickness. So H is most probably the wall thickness. So I was saying that the concept of increase in tension due to the increase in the pressure is valid if we accept that this equation is right. This is right because it is the law, Laplace law. But if we want to use our brains and want to go into that direction, so let's try that. I'm not sure if I would succeed in that, but let's try it. Okay, so we are saying that there is hypertension, and due to hypertension or maybe aortic stenosis, the walls have to contract higher. What is the meaning of tension? The tension can be taken in either direction. Like there is blood inside the heart, and the walls have to pump this blood outside. Okay, so now either the tension can be taken as the pressure that the blood is exerting against the walls, or the contractile forces, the forces or the pressure that is exerted by the contraction of the wall on the blood. So it can be taken in either direction. You may say that the tension is actually the force that is required to push the blood outside. That is tension. Or you may say the tension is basically the stress on the wall that is being created due to the accumulation of the blood inside the left ventricle. In both ways, the meaning of tension is just the same. So whenever there is increased volume or increased pressure overload inside the ventricular cavity, or maybe the atrial cavity, or even in the blood vessels, we say that the tension on the wall of that particular organ is increased. I hope I could make the concept clear. And if I'm unable to make the concept clear, so just stick with the conservative approach or the orthodox approach that the Laplace person, the Sir Laplace, said the right thing, and we have to go with the flow. The preload increases radius of the left ventricle. Chronic valvular disease, aortic or mitral regurgitation, it will increase the wall tension, and that will result in the volume overload. Now, we are talking about preload. I just said that either increase in the pressure or volume, both of these things can increase the wall tension. Now we'll see how the preload is increasing the pressure, the tension. Chronic valvular disease, for example, the aortic or mitral regurgitation, we'll see the pathology of that as well. But remember, for right now, that whenever there is aortic or mitral regurgitation, suppose this is the left ventricle I'm drawing right now. So the aorta is regurgitant. So whatever blood is pumped into the aorta during the diastole, that comes back. So basically, there is increased amount of the blood in the left ventricle that remains in the left ventricle for longer duration, or you may say diastolic volume is increased. So in that case, there will be increase in the wall tension. Now, this wall tension is exerted by the amount of the blood that is present inside the circulation, and that amount of the blood, that increased amount of the blood in the ventricular cavity, is exerting the force on the wall of the ventricles. So that is how we find increase in the tension wall, increase in the wall tension that leads to volume overload. Now let's talk about pressure overload and volume overload separately. So the pressure overload due to increased afterload, that is maybe hypertension or aortic stenosis or something else, which is increasing the total peripheral resistance and increasing the demand of the heart, blah blah blah, forget about it, increasing the afterload. Hypertension and aortic stenosis, concentric hypertrophy to the ventricles, sarcomeres are added in parallel. That is such a beautiful and important concept. I guess there's a picture. Oh yes, there's a picture. We'll see that later on. So sarcomeres are added in parallel if there is pressure overload. Then left ventricular mass is increased, wall thickness is increased, decreased compliance, that is stiff ventricles will be there, often seen in the diastolic heart failure, and the heart sound, the gallop which we see in these conditions is the S4 heart sound. Okay. The volume overload due to the increased preload, that is the venous return. For example, there is increased venous return due to some reason, there is hypervolemia due to some reason, or maybe there is chronic valvular disease like valvular regurgitation. There will be eccentric hypertrophy to the ventricles. The sarcomeres are added in series, right? So suppose that, okay, we'll talk about that later on. Sarcomeres are added in series, longer myocytes, ventricle mass is increased, and wall thickness is not increased, just the size is increasing, okay, and the mass is increasing. So the gallop that we see in this condition in the diastolic heart failure, that is S3, because eccentric hypertrophy ultimately leads to the diastolic heart failure. Oh, I'm so wrong. sorry. The gallop that you find in the systolic heart failure, because the eccentric hypertrophy that is enlarging the heart will ultimately lead to systolic failure of the heart, and that kind of gallop that you find in this condition is the S3 heart sound. Okay, now let's see this picture. The concept of concentric and eccentric cardiac hypertrophy, this is normal. Like normally the right ventricle is thinner in comparison to the left ventricle. If we have pressure overload, for example, in the case of hypertension, pressure overload, yeah, for example, in the case of hypertension or aortic stenosis, as depicted over here, there will be sarcomere addition in parallel. Suppose that this was our initial sarcomeric width or thickness, so the sarcomeres are added in parallel, and ultimately we have a thickened ventricular wall. The mass and the thickness, both of them are increasing, and the cavity size is decreased to this level. Like this is very small or shallow cavity in comparison to this one. So concentric or left ventricular hypertrophy, we see this in the case of diastolic heart failure. We see that in the case of diastolic heart failure, and the gallop that is heard is S4 heart sound. The volume overload, in that case, aortic or mitral regurgitation, or maybe ischemic heart disease or dilated cardiomyopathy. So in the first condition, more and more blood is retained inside, and in the second condition, the heart cannot pump the blood because of its failure to contract. So that is the condition. In that case, the sarcomeres are being added in series. So they're connected in series, like over here. So the ventricular cavity size is increasing, the luminal cavity size is increasing, but the ventricular mass is also increasing, but the ventricular thickness is just the same. The thickness is just the same, right? And eccentric ventricular hypertrophy. And if this led to heart failure, the diastolic heart failure, so the heart sound that will be heard is called as S3 gallop. We'll see these two heart sounds in detail, but remember, the S3 gallop is for the systolic heart failure, and S4 gallop is for the diastolic heart failure. And now, the word of caution. In the clinical settings, the S3, S4 heart sound, firstly, it is very difficult to identify with a stethoscope, because until and unless you are a pro cardiologist, you cannot differentiate between the S1, S2, S3 or S4, because that sounds so similar. Secondly, if you are able to distinguish them, so normally the left ventricular heart failure causes the right ventricular heart failure, and you may hear both of these sounds because there is no concept of isolated conditions and the isolated pathologies. Because when you are dealing with a living human being, living human person, so there is a complex body, and you're dealing with a lot of things. So there might be presence of both S4, S3 heart sound, maybe nothing of them. So this knowledge is very valid for the step 1 exam, but maybe not valid for the clinical scenarios. With this word of caution, let's move forward to the Kaplan question bank. Scenario: old patient with a wild pulse pressure and hypertension. Why? So the people who are old, they have hypertension with a widened pulse pressure. Why? Because of aortic stiffness, as the atherosclerosis decrease the compliance and increase the pulse pressure. Okay, so when the compliance is decreased, suppose that this is the arterial wall that is now thickened and now it is resisting the dilation in response to every pulse. So resultantly, the compliance is decreased, and due to the decrease in compliance, the pulse pressure is increasing. The pulse pressure is increasing because normally when the blood is entering, the arteries used to dilate, and when they will used to dilate, they will compensate the increased amount of they used to dilate, and they will compensate the increased amount of blood that is entering them, and the pressure, because pressure is equal to force divided by area, right? And now if we are increasing the area of the blood vessel, so the pressure would remain. If we are increasing the force, the area is also increasing, so resultantly the pressure would be just the same, like comparable, you may say that. But in the case of atherosclerosis, or when the blood pressure is, when the person is getting old, so the arteries become resistant to these things. They don't comply with your increased blood pressure. So the increase in force is not comparable with the increase in the area. Resultantly, there is increase in the systolic blood pressure. So if the systolic blood pressure is increasing, resultantly there will be a dissociation or isolated systolic hypertension that is seen in the people, old people. What is aortic regurgitation? There will be volume overload, synthesis of new sarcomeres in series, eccentric hypertrophy. In case of aortic stenosis, there is pressure overload, synthesis of new sarcomeres in parallel, and concentric hypertrophy. Regulation of blood pressure. The blood pressure is required for the perfusion of tissues, varies with the sodium and water intake, and regulated by the nervous system. What are baroreceptors? The baroreceptors are blood pressure sensors via stretch. So when they are stretched or when they are not stretched, both the stimuli will go to the brain, and the brain will be made cautious that either the blood pressure is increased, decreased, or normal. Give signals to the central nervous system, that is brain. The response of the brain is via autonomic nervous system. Modify the heart rate or contractility, arterial tone, vasoconstriction, venous tone, more preload and to the ventricle. So when the venous tone is increased, the venous return to the heart is increased, and then the renin release. Okay, so we'll talk about that as well. So these are the methods by which the baroreceptor mediated signal that was perceived by the brain is modulated, and now how the brain is going to respond, that is by the autonomic nervous system, by causing a change in the heart rate or contractility, changing the arterial tone or vasoconstriction, changing the venous tone, and thus increasing or decreasing the preload, and then the renal renin release. Aortic arch receptors and the carotid sinus receptor, these are the two main stretch receptors which are acting as the baroreceptors. The aortic arch receptors, they sense the elevated blood pressure and poor sensing for the low blood pressure. The aortic arch pressure because aorta is such a high pressure system that these receptors cannot sense the low blood pressure. They are just concerned with the high blood pressure. Okay, so they sense the elevated blood pressure in the aortic arch. The carotid sinus receptor, they sense the low and high both blood pressures. Because they are close to brain, they are sensible, they are intelligent, because they're getting closer to the brain. So they are more rational and they can sense both high and low blood pressure. The aortic arch receptors only detect the high blood pressures, while the carotid sinus receptor are going to detect high and low blood pressures. Most important baroreceptor modifies the signal over the wider range of the blood pressure. Okay, response to the hypotension. Decreased arterial pressure that leads to decrease in the afferent baroreceptor firing, increased efferent sympathetic firing, and decreased efferent parasympathetic stimulation whenever there is hypotension. Okay, there is another point. I guess there is a picture. No, there is no picture. Let's talk about that. Suppose we are talking about the aortic arch, and then here we have the carotid bodies. The carotid body looks something like this. Okay, so these are carotid bodies. I'm just going to talk about the nerve supply. So the innervation of the aortic arch is the afferent supply is taken by the vagus nerve, and the efferent supply also come back via vagus nerve. In the case of carotid body, the afferent supply is via glossopharyngeal nerve, and the efferent supply comes back as vagus nerve. So basically, efferent supply does not come back to them. The efferent supply, so the afferent supply from the aortic arch is via vagus nerve, while from the carotid body it is via glossopharyngeal nerve. The CN9, yeah, glossopharyngeal nerve CN9 is taking the afferent impulses from the carotid bodies, and the efferent, that is the response that is going to the heart, and that is coming via the vagus nerve in both the situations, either up regulation of the parasympathetic stimulation or the down regulation, or maybe the sympathetic tone and stuff like that. So that is not your concern. But right now we are, because these are receptors, and receptors are sensory organs, so they have the main thing that you must remember about them is the afferent nerve supply. So for the aortic arch receptors, this is the vagus nerve, and for the the carotid bodies, this is the glossopharyngeal nerve. Okay, so now we are talking about a situation in which we are facing hypotension. So in that scenario, if the person is facing hypotension, so there will be decreased arterial pressure because of hypotension. Maybe the person has had some accident, or there is hypovolemia that resulted in hypotension. There will be decrease in the stretch afferent receptor, so decreased stretch afferent baroreceptor firing, increased efferent sympathetic firing, and decreased efferent parasympathetic stimulation that results in vasoconstriction, increased heart rate, increased contractility, and increased blood pressure. Important in the response of severe hemorrhage. So in the case of severe hemorrhage, we need the increased efferent sympathetic firing to decrease the efferent parasympathetic stimulation that will result in vasoconstriction, increased heart rate, increased contractility, and increased blood pressure. Important in response to severe hemorrhage. Okay, so here you can see acute hemorrhage that decreases the PA. What is that? Arterial pressure. Okay, arterial blood pressure that decreases the stretch on the carotid sinus baroreceptor, that decreases the firing rate on the carotid nerve or the Hurring's nerve, that decreases the parasympathetic outflow to the heart. So the decrease in the parasympathetic outflow to the heart is going to increase the heart rate and ultimately increase arterial pressure towards normal. Also, the decreased firing rate of the carotid sinus nerve, that is the Hurring's nerve, that is the branch of the glossopharyngeal nerve, by the way, that increases the sympathetic outflow to the heart and blood vessel, that increases the heart rate, increases contractility, increases constriction of the arterioles, increases total peripheral resistance. Constriction of the veins will cause decreased unstressed volume. What is that? Increased venous return, increased mean systemic pressure, it decreased unstressed volume. I guess the veins are the pools of blood. So veins can pool a lot of blood inside them. So if you cause a constriction of the veins, so the amount of the blood that was unstressed and that was stored, that volume is decreased. Okay, and then all of that is going to lead to the decreased arterial pressure towards normal. No, increasing the arterial pressure towards normal. Increase in the arterial pressure, remember that, because we are facing hypotension and we are going to cure that. Now let's talk about response to the hypertension. Carotid massage, for example, when we do that, carotid massage, yeah, okay, so when we are facing hypertension or when we do the carotid massage, in both the situations the carotid bodies are overly activated, so that leads to increased pressure on the carotid sinus, that leads to increased stretch. Increased efferent parasympathetic firing lead to increased AV nodal refractory period by the parasympathetic nerve supply and all that. The vagus nerve will cause an increase in the AV nodal refractory period that decreases the heart rate. Component of the Cushing reflex. Cushing reflex is triad of hypertension, bradycardia, and respiratory depression. Let's discuss this flow sheet and then we'll come to the Cushing reflex. So let's go to the Cushing reflex because this is about Cushing reflex. Cushing reflex is basically increased intracranial pressure due to any reason. Maybe there is some cranial injury, or maybe some tumor is in the brain, or some ventricular size is increasing, ventriculomegaly is occurring, or some stuff like that. Any cause of increased intracranial pressure, be it hypertension, so any cause, increased intracranial pressure such that intracranial pressure is more than the mean arterial blood pressure, that will result in a decreased cerebral perfusion pressure and cerebral ischemia, because cerebral perfusion pressure, CPP, cerebral perfusion pressure is equal to mean arterial pressure minus the mean arterial pressure minus the intracerebral pressure, I guess. Cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. Yeah, ICP, mean arterial pressure minus ICP. If the ICP is more than the mean arterial blood pressure, so the cerebral perfusion pressure will be decreased. So there will be cerebral ischemia. Now in the stage 1 of cerebral ischemia, the sympathetic nerve supply is activated, because when the brain is not getting enough amount of blood, so brain senses that maybe there is hypovolemia, or maybe there is hypotension or stuff like that. It will excessively activate the sympathetic nervous system. Alpha, when adrenergic system will be activated, there will be vasoconstriction and hypertension will start happening. The beta 1 receptor is stimulated, that will increase in the heart rate. In the stage 2, that is Mary's law, hypertension will cause the baroreceptor aortic arch or maybe the carotid bodies to be stimulated. Now when these two receptors are stimulated, they will activate the parasympathetic nervous system, and via M2 receptors the heart rate is decreased, and this is the dominant effect basically. And Cushing ulcers will be seen in the stomach because of excessive parasympathetic stimulation, that will cause acetylcholine release on the stomach, that will cause excessive HCl production, and Cushing ulcers will also be seen. So the third one is hypertension will press on the respiratory center, and there will be irregular breathing, that is also called as Kussmaul breathing. Kussmaul breathing. Okay, so there is there are two things associated with the Kussmaul. The Kussmaul breathing that is associated with this one, and then there is Kussmaul sign. We'll discuss the Kussmaul sign in the pathology section. Kussmaul sign basically states that there is paradoxical dilation of the jugular veins when the person is doing the deep inspiration. So that is Kussmaul sign, but we'll discuss that later on. For right now, remember that there is a triad of hypertension as we saw here, bradycardia, because the parasympathetic stimulation is a major or dominant stimulation, although the beta 1 receptor is causing increased heart rate, but the dominant one is this one, decrease in heart rate. So we'll find a net bradycardia, and the respiratory depression or respiratory abnormality, abnormal respiratory pattern will be seen in the person who is having increased intracranial pressure. So we'll talk about the chemoreceptors in the next session. Until then, Allah Hafiz, Fi Manila, and take care.